partners. Our expert faculty today is Mary Minetti. Mary Minetti is a close partner working with us on our SAN grant. She's the Senior Policy and Program Specialist at the Institute for Patient and Family-Centered Care. And along with Mary today, you're going to hear a story from a practice. From HRHCare, we have Catherine Brieger and Norma Johnson, who are going to talk about their partnership toward quality improvement in their practice. So Mary, I'm going to go ahead and turn it over to you.
Thank you so much, Amy. And welcome, everybody. Thank you for joining us today. I am very excited to see and talk with you about the project. For some reason, the slide's not moving forward, and I'm getting a circle. So if you guys want to move to the next slide. I just want to let you know that in addition to all the wonderful resources that are going to be created and sent to you by email and on the PCPCC website. Now it looks like the slides are moving forward without me, so we want to move back a little bit. But the website for the Institute for Patient and Family-Centered Care also has a primary and ambulatory special topics section, and we encourage you to take a look at the different free downloadable materials that we have. I want to just kind of set the stage and then get Catherine and Norma to really talk to you about how they implemented patient and family-centered care and involved patient and family practice partners with them. So patient and family-centered care, and that's the framework I'm going to kind of share, is an approach to the planning, delivery, and evaluation of health care in partnership with those who receive care and those who deliver care. And we want to really focus on that it's a mutual partnership, that we really want to work together toward common solutions that are going to meet everybody's needs. If you can only remember one thing about patient and family-centered care, it's that it is working with patients and families, not just doing things to or for them. So it's really around partnership. And what you see in the slide in front of you is a little more information about those four concepts of respect and dignity for all, about how important it is that healthcare providers communicate and share information in ways that people can understand, that they can put within the context of their lives, their values, their beliefs, and their preferences. And it's really important to connect with patients in that way. And one of the things that practice partners help us do is be able to understand from the patient and family experience what really is of value and what information that you're sharing that really is clear and understandable. Really helps with health literacy kinds of things. And then, of course, in all care, patients and families are essential members of the healthcare team, and we want to support and encourage them to participate in the care and decision-making to the level that they choose. And we're going to be talking a little later about, and you're going to see some examples from Catherine and Norma around how they have collaborated with patients and families in policy and program design and those kinds of things. So next slide. Okay, it's here. So we're talking about providing a framework because what we're about is really transforming healthcare so that it really moves from patients and families being passive recipients of care to being active partners in care. So you need to move the next slide because it's not moving again. So there have been a number of articles written, a number of professional associations, the Association of Family Practice, who have really come out and written lots of articles around how putting patients and families on improvement teams is a key lever for transformation. That is where we really have not just incremental change, but really stunning levels of change. This slide that you see in front of you is a health affairs article that was all around patient and family engagement, really talked about it in February of 2013 as being the blockbuster drug. At that time, they had a number of primary cares. They're trying to get certified as patient-centered primary care homes. And they surveyed 112 patient-centered medical homes. And what they found is that nearly all practices solicited patient feedback, but only 32%, less than a third, involved patients and families as advisors, as practice partners on QI teams or councils. And what really makes a difference and why those practices that said not only do we collect patient feedback, but we work in partnerships with patients, was because leadership, clinical leadership and administrative leadership, no matter how small or big the practice, felt that that was essential. Next slide, please. Those practices that did both, gathering information through surveys, through conversations, through CG CAPs, and those who also did what they described as robust patient involvement in every aspect of the practice, from designing new programs to evaluating current informational sessions, said that it really positively affected the way in which patients and families interacted with physicians and staff, and it created stronger relationships for the team. And often in patient-centered primary care homes, the main transformation is around the transformation of delivering care in a team fashion. Next slide. So I want to talk a little bit about what a practice partner is. Some people call them patient and family advisors. For this particular TCPI effort, we're really talking about practice partners. We're talking about people who really want to help the practice to work in alignment with the practice on things that they both feel are important. Next slide. So a practice partner is any role in which people who receive care and their family members work together with healthcare professionals. They share insights, they share perspectives that people who are in the practice delivering care don't see. They bring a certain expertise that's important to be aware of. They don't diminish the expertise of other members on the team if it's a quality improvement team, but they really add value to that situation. Next slide. This is a picture, it talks about changing the assumptions and really looking at patients and families as, I don't see the next slide going, but I'm going to talk about this great picture. This is a picture of a doctor in a small practice. There were 4 clinicians in a small rural practice who were really interested in changing the assumptions and really inviting patients and families to partner with them on changing practice patterns. And the picture that you saw a moment ago is he took his picture and put it into an Uncle Sam poster and then printed these posters in his practice as a way to create conversation from the moment people checked into the front desk and into the exam room, to begin to have conversations with them about that they were going to be making changes in their practice, that they really wanted to invite patients and families to be involved in those changes. And it was a great conversation starter, wonderful way to recruit people and also alert people that changes were going to be made. Next slide, please. So there's lots of important reasons why to involve patients and families in change in your practice. And one of the things that I hear from physicians that I've worked with across the country is that patient and family advisors really dampen the cynicism sometimes we feel with the burden of all the requirements outside of our practices, and really help us understand how much patients and families want to help. It can provide feedback that is very timely to save money, and it also gives the staff an opportunity to really be grounded in the reality of what the patient experience is. Next slide. So we want to create strong partnerships with our patients and families, and it's important as we're thinking about inviting people onto our teams, potentially onto our boards of directors, into our chronic care management improvement efforts, that we want to identify people who have certain qualities and skills so that they can participate meaningfully and in a positive way. So they're people that have to be able to share their personal experiences in ways that other people can learn from. They're interested in the bigger picture. They're not just a person who looks at one issue, but they can look at broader issues. They are able to listen and hear other people's points of view. They have a great sense of humor. That can really make a difference. And they also, and this is key, really represent the patients and families served by the hospital and clinic. Next slide, please. So I wanted to get ready to set the stage for the great information and practical information that Catherine and Norma are going to share with you. And this framework is very helpful as you think about different ways that practice partners, patients who are served by the practice and their families, can help you by providing information and really partnering with you on those changes. It can go anywhere from pretty light engagement of ad hoc input like with surveys or focus group participants. But in a patient and family-centered care system, we have to go much deeper. Structured consultation, and I'll be talking about different ways to do that. They're going to share information about how they're doing it. Has to do with councils or involving people in QI groups. And then as the engagement deepens, often practice partners can be co-leads on important initiatives, possibly facility design or the implementation of a patient portal. But it is important to consider ways to help prepare advisors, and I'll talk more with you about that later. Next slide, please. But I'd like to turn it over to Catherine and Norma so that they can really tell you what the experience has been in their practice. Catherine?
Great. Well, hello everyone. We're so happy to be on the call. We're going to be going to the next slide, and we'll tell you first what is HRHCare, and we'll talk a little bit about how we were able to take this on. Could I have the next slide, please? Okay. So we're a network of federally qualified community health centers. We're 29 centers in a 10-county area of New York. We were founded over 40 years ago by people from the community who were actually patients. We have about 1,000 employees, and we see over 130,000 patients a year. And those patients are people who are getting comprehensive and preventive health care. We are a Plaintree Healthcare affiliate. We've been part of the Plaintree Healthcare Alliance since 1996. We are the only federally qualified health center that's part of this group that really looks at patient-centered care as a core of really function. We are also a Davies Award winner, which is the national award for use of data in improving quality. We are a New York State Health Home, member of an ACO network and Health Center network. We're a level 3 patient-centered medical home, and we have diabetes recognition. We're Joint Commission accredited. And then we also participated in the healthcare disparities with IHI and HRSA. So in a nutshell, next slide, please. I wanted to make sure that you understood that when you look at our system, you may say, oh, this is so big, it has no relationship to what we're doing in a small practice. But I have to say that in some of our practices, we have 2 exam rooms with 1 physician. We may have a site that has 2 physicians or 1 physician and nurse practitioner. So the building and the team may be very small, and yet we've been able to do some of the same things in all the sites. So that we also, if you look at our program, we have sites that are rural and serving farm workers, and others that are very much in a suburban area, and others that are in urban areas. So we pretty much cover the gamut. On that note, if we go to the next slide, what I'd like to do is to talk a little bit about our mission, which is to increase access to comprehensive primary and primary care. And in order to do that, we found from the very beginning, as an FQHC, you must have at least 51% of your board members be actual patients. So this is a legislative piece of being a federally qualified health centers. So our bosses are really the board of directors who are patients. So in some ways, it's a fundamental part of who we are and who we've always been. So a little bit about board selection, and then on the other hand, we have quality patient advisors. So our board members, you're going to be hearing from one, Mrs. Norma Johnson. The selection is really made from the communities we serve. So you might see that we have a large geographic spread, and so we want to make sure that we reflect the patients that we are serving by our board members, and so we do analysis a couple of times a year by gender, race, ethnicity, and also sometimes by special population. So we may have people who are recently homeless or just going into transitional housing. We may have people who are farm workers, but most importantly, they are patients of our center. They often are nominated and then by the other board members, and then they are voted. That we have a vote of the board members by the board to elect people into the board. Then they serve on a number of committees. Some are more active than others. Mrs. Johnson will show you that she's been very active in a number of things, and she knows everything. That's why we asked her to be the presenter. We also in order to get training on how to be a board member, our National Association for Federally Qualified Health Centers allows us to have training, both local and national, for our board members. We also supplement it by training of our own that we've designed. And so we feel that that's a great way of becoming oriented. Now, on the other side, and I see this maybe as being more feasible for the smaller practices on the call, we actually have patient quality advisors, and those are people who are asked, if they're patients, and they're asked if they'd be able to be part of our quality evaluation. We've had patients involved with, and this is, by the way, separate from the board, again, we've had them involved with patient cycle time, which tells us how long it takes for a patient to get through a visit and what's happening. We also are having them help us by doing site walkthroughs, asking to see from their eyes, what do they see in the center? Is it clean? Is it orderly? Does it seem like they're getting treated in a way that's respectful? We also have these patients work with us on design of programs on health and wellness, asking them, all kinds of questions about what do they want, what do they see as effective. We also have them help us with identifying outreach techniques and also actually outreach. We have, today I'm doing a plane tree training for our staff, and today we heard at our Beacon site from one of our patients who actually delivered a presentation on what do patients want to see in their typical visit. That's very inexpensive to do in a small practice. Urban or rural can easily do this. We also are developing communication guidelines. We have communications guidelines for staff, but we are just finalizing the ones for patients, and who best to help us write those are the patients. So we're actually getting input on our patient communication guidelines, and that is, how do you want to be communicated with from the practice? So next slide. I would like to introduce you to the idea of this board of directors before Mrs. Johnson takes over. Again, 51% must be patients. They reflect all aspects of HRHCare, and they review staff satisfaction surveys so they can help us to know, are we going in the right way. They also help, this month they'll be reviewing the staff training plan and be giving us direction on what they think we might need more training on. They also grant privileges for the providers. Even though we have an outside credentialing body and we do internal review of license, it is our board of directors that grants final privileges and assignments for the providers, which is really a little different than most places. They also review financial reports. They must approve our financial reports every month. They help to set the hours of operation and site location and services. So if we are opening a site, they'll ask us, hey, what about evening hours? What about Saturday hours? So they're very much involved with most of the management side of what we're doing. And the last thing that also they do is also review patient experience reports and the quality initiatives. And this becomes extremely important because they have helped to shape much of what we've done. Now, let me stop talking and actually introduce you at the next slide, Mrs. Norma Johnson, who is one of our most seasoned board members. She's served on the board since 1977. She serves as co-chair of the board, also on our quality committee, and she's really been a patient for the same length of time that she's been on the board. And I have to say, you better have your act together when you're doing your presentation, because she will look through and make sure that you're doing everything correctly. And I love that, because it really makes us all be aware, and she always has great questions to ask. So Mrs. Johnson, I'm turning this over to you.
Thank you very much, Kathy. I don't know if let's have the next slide, if you will, please. How much more you need me to tell you what I have done. As Kathy said, we review incidents and patient complaints. And not only do we review those complaints that come from patients, but we also review complaints that come from board members, because as patients in the centers, we may find things that need to be corrected, and we are certainly going to give you that information. We also evaluate activities and services for patients, including outreach. Now, it's very important as board members that we become a part of our community, and that we become advocates for the center when we go out, so that if there are any times when people come to us, we are supposed to let them know that they can come to us and that we will bring their complaints or corrections to the center. Hasn't happened very often, but every now and then we do. We also review all of Kathy's training plans, all of everybody else's training plans. And we also evaluate and review the staff satisfaction results. It is, to my way of thinking, the most important thing that the board member can do. In addition to being a patient of the center, it's also important that we become an advocate for the center, which means that anytime someone has a question or problem, we should be able and willing to answer it and or find the answers for them. We are also, it's important that we involve ourselves in our churches, our temples, or where else that we might find people, like in our civic meetings, so that the health center is always visible. Next slide. Okay, that was my last slide. Thank you.
Yes. Thank you, Mrs. Johnson. So, and I remember we did have an issue. This is something specific that Mrs. Johnson worked on. We had a few years ago some issues around our dental patients were complaining about front desk reception not being as friendly and respectful as they should be. Mm-hmm. And we did some research and found out, what was causing this. Was it a training issue? Was it just counseling on certain people? And we found that there were actually some system issues that created a uncomfortable feeling for patients around payment and around when they had to have special care and when they came, if they came late for their appointment, all these things. And so we did an intensive revamp of our dental, the front desk, training, and have really, since that time, have included them in all of the training for front desk. And we saw a very big improvement in our scores as a result of this training. But how it really came out was this input from Mrs. Johnson, especially, and some of the other patient advisors on our board. So anyway, let me move to this slide, which is community advisory committees. So in our communities, we may have special populations that we serve that have formed community advisory committees. And those are not board members, but they do help to provide us with some very useful information. And we use their information in any of our programs, including education, outreach, and services. So sometimes they may prove helpful in finding out what are needs that exist in a certain community. For instance, our HIV community, we have a special community advisory program, and they're able to give us information for people who may be living with AIDS or affected by HIV. They serve often as ambassadors, just as Mrs. Johnson mentioned about board members. They serve as ambassadors and help us to really outreach into the community and provide great care and services. They also, in this program here, we actually are part of the Reach Out and Read program, in which we give our patients books that are age appropriate during their visit with their pediatrician. In this case, they're also doing a reading program in some waiting rooms or waiting areas. This one happens to be outside of one of our farm worker centers. Next slide, please. So how do we know what we're doing around patient and patient engagement and patient experience? Because that's really at the crux of what are we doing right and what do we need to fix. So we've been collecting CG caps, which is the clinical group caps, unlike a hospital caps. And this is for practices, small clinical practices. The ones we use are actually done by phone only. We found that many of our patients did not like to complete surveys in writing. And we ask for 20 surveys per provider for each quarter. We have about 100 providers. We provide the results back to the provider groups, and we do a variety of actions based on those results. We're able to compare ourselves to other SQHCs as well. So we can see, I think there are about 20,000 patients using the survey, so we actually get a lot of good comparison and benchmarking. We also get information that's actionable. How long did you wait? Did the site seem clean? Were people respectful? Did your doctor communicate in a way that you understood? All of those things really help us to know whether we're working with our patients in a way that they like. We know that surveys are only one way of gathering data. And so for some of the small practices, you may want to use this idea. We started focus groups a few years ago, and we do one a year, sometimes twice a year at a site. We ask a group of patients. We're usually looking for a small group. You can even have 6 or 7 and it'd still be great. And they're people who've had a recent visit, either dental or medical. And we ask them 3 questions. What do you like about the services here? What don't you like? And how can we make it better? We ask them for 1 hour of their time. We make sure that there's no actual staff there because we want to make sure that there's no feelings of hesitancy about telling us what they feel. And we offer them a $25 gift certificate. Even though the small number of people may not seem like a very valuable thing, we have found very good information can be gained from these focus groups. Next slide, please. So how do we use this data? We actually use the data to recognize staff that are really doing well. We have the top, right now we just finished our last quarter's completion of the top performing sites for each area and the bottom performing sites. And so what we do is we're going to intensely treat the ones at the bottom, but we're going to use the stories and some of the workflows that the best practices have actually been able to use to have great scores so that they can help to educate and help the other sites that are not doing so well. We also give feedback every month to the board of directors and the executive team. Mrs. Johnson will see these results. Actually last month she saw these results, and so every quarter they're going to be reviewing and knowing what are you doing to make things better and what are you doing to recognize places that are doing great. We also integrate into the training plans when we see areas of weakness. So 2 of the areas that we saw this last quarter were people weren't aware that they could call 24 hours a day, 7 days a week, and get access to a provider on call. So, and the other thing that we found was that people were not informed of wait if the provider was delayed in the waiting room. So we know those are 2 areas that we have to hit hard on. And so we're going to be measuring after our intervention next quarter to see did we make any difference with our intervention. They also are used in provider compensation. That patient experience is just as important as quality and productivity in their score because we feel that those are measures that cannot be diminished. Their value cannot be diminished. With the focus groups, we provide that data back to the senior leaders, the site leaders, and also the board. It's integrated into the board report. We also, again, use that information to shape our training programs as well as staff recognition. Can I have the next slide, please? So here just, I want to say that the value of patient stories has really been clear to us. As part of Plaintree, we learned early that by telling patient stories, it's really a motivator. If any of you have read the book Switch, they talk about how important it is to really get the emotional side or really connect people to the humanity. And I think that staff respond so well, even though they see patients every day, seeing them as human beings with unique needs and concerns and lives really is a powerful way. And what better to do than to actually have them be part of these stories and to hear them. And how we share the stories is that leadership teams, sometimes at the board meeting, will share those. But keeping the patient as a human being at the forefront is really critical. Next slide. So when we develop these communication guidelines, we want to make sure that patients are asked, how do you want to have the information that's going to help you to work with your care, with your treatment? What works best for you? And how might we have a patient portal? How might the patient portal effectively help you to get information you need? And also in getting appointment reminders and things like that. What works best for you? Patient portal, texting, mail, or mail? We've actually included, as I mentioned, some of the patient voices. And one of the youngest patients that we have, I think she was about 10. She told me that her mother should get reminders for the specific child that she's bringing in, because she said, my mom has 3 kids, and if I get a reminder call and there's no name, we don't know which kid to bring. And so listening to your patients, no matter how young they are or how old they are, really is critical. We try to send the message to our staff that we walk with you. If you could go to the next slide. This is one of our patients, and the message that we do in training is always the idea that we're with you, we're not walking or pushing you, we're walking with you. Next slide, please. So we also use staff recognition as a way to make sure that staff are being pulled out and hailed for all the work that they're doing outside of their normal responsibilities. So every month we select people for innovation, for having the Plaintree spirit, and people really love this. Can I have the next slide? Staff training. As I mentioned, we do a lot of live training, and also always remind patients about feedback. Always use the patient's stories, because again, that gets back at the patient experience. And one last thing is always making sure the patients are included in these stories. Could I have the next slide? So this is a sample of the patient cycle time, and patients are asked to track what they're doing as they're going through the system, and they've really given us some great information. In some cases bad, in some cases good, but from this one you'll see what happened to this patient. We are able to go back and say these are things that we have to change, and the patients love it, being part of a quality improvement program. Next slide. So I wanted to end by saying, you know, at HRHCare we really listen to the patient voices by way of our board members, by way of the focus groups, by way of individual input from the CG CAPs, and then just sometimes asking patients, will you be a part of our quality review? If you're a small practice, again, doesn't matter if you're rural, urban, patients want to be involved. And when you ask the question, that alone makes them feel, hey, I'm really important, they really care about me. So I urge all of you to think about, if you can begin with one person, and this is Juana, who comes to us. She doesn't speak, she speaks a dialect from Guatemala, and she participates in some of our farm worker programs. And I think of her because she doesn't read Spanish or English. We have to give her information. She's allowed me to tell everybody that she also has diabetes, and so she has to learn how to manage her condition by way of non-written communication. And so by really understanding and listening to her, we've been able to really deliver care in a way that's going to help her. And really, that's the very bottom line, keeping patients at the center of all that we do, everything that we do. We'll be a better practice, we'll have a happier staff, we'll have more satisfied and better outcomes with our patients, and overall, we'll really be a patient-centered medical home. And that's the end of my talk.
Thanks, Kathy. So as you can see from the many examples that Kathy and Norma talked about, patients and families in their practice are essential partners for innovation, quality improvement, and healthcare redesign. So I want to talk a little bit about what are the best practices to be able to really get to those strong partnerships with patients and families. And one of the things that both Norma and Kathy talked about is being able to have people who are part of the population you serve involved in, whether it's focus groups, whether it's integrating them into a cycle time improvement. You want people that represent the populations, and often people who've had recent experience with your practice. And one of the ways that you seek advisors to represent those populations is you find out who are the trusted sources of community for those populations in your larger area, and often partnering with those groups, whether it's a religious faith community, whether it's a support group, whether it's a particular social service organization, they can help you with your advisor recruitment. It's important to be really clear with people who you are inviting to be partners with you in improvement, to be clear about what the role is. Here's what we're going to do in this group, here's what we're not going to do. We're seeking input in this group, or we want you to help us make the decision. Those things will vary depending on what you're trying to improve and who is on the team to improve that. So you want to be able to find and select people who fit those particular roles. And so somebody who is comfortable telling their story in a staff orientation so that people experience what it's like to receive care and what works and what doesn't work. Maybe a different kind of person than somebody who really wants to work on a cycle time improvement. It is important to orient them to the organization to provide them with ongoing support and coaching. The other thing that is important is do not invite people to provide you with input if you really aren't going to value the input or utilize it in that particular activity. That often is one of the things that creates a negative experience for people. And there are some things in your practice that you will be doing without patient and family input. And that, it may be how you are interacting with the insurance companies or something that doesn't directly impact patients. But identify what you're already working on and think about ways that you can involve patients and families to provide you with input. And then it's really important to let your advisors know, your practice partners, how you've used that input. If they're on a team that's actually making changes, they'll see how that input has been utilized. But sometimes when you're on a board or you're on a council, you might not see how that input's being utilized or why it wasn't utilized. No partner I've ever worked with or that I've heard of across the nation expects every idea that the patient practice partners come up with will be implemented in the practice. They understand that there are boundaries and limits and those kinds of things. But it is important for them as part of their ongoing educational experience and partnership with you for you to be transparent with them about why something wasn't able to be used. And the whole reason and the whole purpose and the outcome that you're looking for is that you're providing meaningful opportunities for people who are volunteers because they want to feel like they're making a positive difference. We talked a little bit about recruiting advisors throughout the effort, and I'm not able to do my slide again for some reason. The number one best way to recruit advisors, and this is a picture of a doc in rural Michigan who is actually on the phone calling some patients that he provides care to let them know that they are recruiting for a particular chronic care improvement team and he's interested in inviting them to participate. Not all physicians need to get on the phone, but the number one best recruitment source for advisors or practice partners is referrals by clinicians. Can be the nurse practitioner, can be the behavioral health specialist, can be a variety of clinicians who have a personal relationship and might say, yes, I can think that Norma would be great on this particular team as an example. And then somebody would contact them and say, Dr. Smith recommended that I contact you about a chance to join us in a team where we're going to improve care for patients with diabetes as an example. But there are other ways to recruit patients. And one of the things that came to mind as Norma was talking is that current advisors are great resources for knowing their community and perhaps suggesting people that they could bring in to the practice who might be able to contribute as well. And as Kathy was talking about the focus groups that they hold, often when you're doing a focus group, if you're thinking about changing something and you're having a generic conversation in your focus group, you might be able to then at the end of that focus group let people know that there are opportunities besides this one-time meeting to join with and work with the practice on improving some aspect of care. Next slide. This next slide is an example of a recruitment tool to make it easy for clinicians to refer patients. And this was the size of what would have been old prescription pads, that used to be able to fit in the white coats. And it was a double-sided piece of paper. And on one side, it talks about the qualities of advisors and what are the considerations if you're interested in being an advisor. And on the other side, it's a little paragraph that talks about, I, Dr. Smith, think you'd be a great advisor. But knowing how busy practices are, sometimes we can't have a big conversation. So a clinician in the moment can say, Mrs. Smith, I think that you'd be a great advisor. Here's some information. If you'd like more information, you can contact somebody. Next slide, please. So how do you get started? You begin to identify who in your practice might have the qualities of an advisor. So an initial structure is you might have an informal work group to begin to talk about different ways in the practice, different things that are going on, and talk about how advisors can be involved. A patient and family advisory council is a more ongoing structure to involve patients and families. And then we've talked about being on safety or quality teams, or specific issue teams like improving diabetes care, or improving care for hypertension. So lots of ways to start. There's no right or wrong way to start. The idea is to invite people, support people, and help them be able to be effective. The next slide, please. These are some of the characteristics of patient and family advisory councils. I'm not going to go through them because we want to give you time to ask questions. But what I would really suggest that you think about is who within the practice is going to be the leadership support for this particular group. It meets on a monthly basis. Topics come to them. They raise topics. They partner in key places in the organization. Often an advisory council can be very helpful in helping you make sense of your survey results. So people answered not so well on this particular question. Well, what does that really mean from the patient and family perspective? And often practices have found those conversations with patient and family advisors great before they start making changes to their practice, because often they're guessing at what we might be able to change that would change the score on this particular patient experience survey. Next slide. I think it's important to understand that the purpose of an advisory council is very specific, and it's not just an opportunity for people to get together and be a support group and meet other people. That's not the purpose. It's to do real work, to provide real input on meaningful things that the practice cares about and that patients and families receiving care at that practice care about. And so that, as part of being clear on what the role is and what kinds of decisions and input and topics that are going to be covered, can often help orient people to this particular kind of group. Because you may have self-management support groups in your practice as a care delivery, which is very appropriate, but it's important to stay clear that that's a different kind of group than an advisory council. Next slide. So there are a number of things in these next three slides. Kathy and Norma talked a lot about all the different kinds of other advisory roles that are possible, and I'm not going to go into any more detail about that, but you'll have that in your slide deck. Next slide, please. When you invite a patient and family partner to come and join you on a particular team, especially something that's been going on for a while, it's important for you to orient them to what that team's been about, what's been accomplished already, and what are the kinds of things that that team is working on in the future. So I really encourage you to, I really encourage you to think about how you prepare people to join you in this new role, because this is a different role than being a patient who's receiving care. It's really helping understand how that care impacts patients on a broader level so that you can improve for all. The other thing that's important in terms of a best practice is not everybody in the practice, the staff, the clinicians, are going to feel comfortable, next slide please, in how to work with patients and families in these new roles. So in addition to helping and preparing the advisors, and these are some other things that you can cover with advisors, next slide please, is to really think about how to prepare staff as well. So we're about 2 slides behind. So what you want to do with patients and families is to let them hear how other advisors have worked, and there are a number of resources that are available, stories of people working as advisors that are available on our website. And we have had advisors write a book for advisors to really talk about how to be effective. And if you have them involved in quality and safety committees, it's important to identify a mentor who can work with them and debrief their meetings with those groups afterwards to make sure that it was meaningful and to see if there were any questions that they had. Next slide, please. Here are all of the things that sometimes when staff and clinicians haven't heard about practice partners before and haven't had on-the-ground experience with that, they will raise these issues. And your role as a leader in encouraging practice partners to be part of the way you do work and make change in your organization is to address these issues. Next slide, please. So to do that, you have to raise what are the issues. Say, we are going to invite practice partners. Here are some ways other organizations have done this. What are your issues and concerns before we start inviting practice partners into an ongoing team? And then be sure and help them understand that you're going to prepare advisors to respect confidentiality. And one of the handouts that you're going to have is a confidentiality agreement form for practices to share with advisors and have them sign that they will, in fact, maintain confidentiality. The other is to share stories. You've heard some stories on HRH about ways that they've used advisors. As you're talking about this with your clinicians and your other staff, you can share those stories, and that can help. The other thing is to help advisors help clinicians and staff understand that when you start working with advisors, it's important to ask questions and then listen. Next slide, please. So we want to be sure that people understand that they're going to kind of listen first, that their job is to be open to questions and feedback, and to try not to be defensive as they hear. And that's a key, because it's really easy to take the feedback personally. Next slide, please. So listening is very important, and next slide, please, because we want to understand their perspective. So how did that feel to you? What, as we bring people in and welcome them into the practice, new patients, how do we make that be a better experience? So we've talked a lot about the outcomes and benefits, but one of the things is practices are businesses, and often involving patient and family practice partners can help you avoid costly errors and can provide information that helps you make better business decisions. Next slide, please. So we've covered a lot of territory in this period of time, and we wanted, as I said, to give opportunity for you to chat in questions. You are going to get these resources and tools, and I just want to give you a heads up about each one of what those will be. We went through slides fairly quickly today, and so if you want to read more about it, you're going to have the slides. We've developed at the Institute for Patient and Family-Centered Care a 20-page document that reads very easily in small sections called Advancing the Practice of Patient and Family-Centered Care. And it's very good at setting a foundation, having some checklists that can help you think through how to get started. If you've already started and you've heard some things today that you weren't familiar with and you want to go back and think about those things, this Getting Started resource can be helpful as well. In your packet, you'll see a number of patient and family advisor job descriptions and that sample confidentiality agreement. And that can help you as you're trying to identify what are the roles that you want advisors to play. Next slide, please. For those of you that might be patient and family practice partners, or for those of you that are going to take a leadership or coordinating role in your practice to bring and orient and support patients and families in being meaningful practice partners, we invite you to join our Patient Family Advisory Council Network. It's a learning community. It's open to patient and family partners and those that they work with, and you have the way to join that. It's free. It's a wonderful network of over 1,200 people that have been doing this work for a while. So I'm going to turn it back over to Amy so that we can do some Q&A, and I thank you very much for your attention.
Thanks so much, Mary, Kathy, and Norma. This is great information. And again, this is just the starting point for a lot of the information, supports, and training that we're going to be providing as part of the TCPI network. A few things that we'd just like to really talk to you about as we wrap up, and some of the supports that we'll be providing through the PCPCC in conjunction with our partners at the Institute for Patient and Family Centered Care, Plaintree, and YMCA. Again, they already have developed a lot of these tools and resources, and we just want to make them as available to you as possible. We also want to take a lot of that burden away from you as practice partners to really help support those patients in their role. So we'll have some targeted activities and training opportunities for those patient partners, but ideally we'd love to be working with both of you together, with clinicians and patients always together, and really fostering that partnership. Some of the greatest ways that I saw patients being integrated into quality improvement was really truly bringing them onto your quality improvement team. So I worked and saw some practices in southeastern Pennsylvania, and every Wednesday at noon, their 2 patient partners from the practice would come and meet with the quality improvement team. They'd go over all the data from the practice that week. They'd focus on and help them prioritize what are some of the activities that they should be working on in the future, and some real incredible strategies that they advise them on ways to improve things that you wouldn't necessarily think that patients from the practice would have some great thoughts about. But, you know, improving the number of patients who receive flu vaccines. They came up with some great strategies for putting up some information to communicate that up in the waiting room. I loved what we heard about fostering these relationships with community partners and helping the practice, the clinicians, become more aware of what's available out in the community in regards to these supports. So there's just this plethora of ways that you can engage and work with patients and family partners, and we hope, especially for all of the practices who get enrolled as part of the Transforming Clinical Practices initiative, that you really engage with a couple of your practice leaders right from the beginning, because again, we find that if you start to work with them, bring them on as part of your quality improvement team earlier than later, you're going to have much more success. And they're going to really help to be able to spearhead getting families involved in these other ways, whether through focus groups, through forming patient advisory councils. There's just so many ways that you heard Kathy and Norma talk about, and it might take a while before your practice really figures out the best ways to engage patients and families in all these different aspects of the practice improvement activities. But again, bringing a couple leaders from your patient population early on is going to be, I think, huge and very important to your success in clinical transformation moving forward. I apologize that we don't have a whole lot of time to answer questions. We'll be following up with some of you individually. But Mary, one of the things that always comes up to the top of the list in terms of what we need to do in supporting patients in their role and their expertise is the compensation. How do we compensate patients who become active partners, whether it's on a board or whether it's as part of a focus group or whether they're really a key piece of the quality improvement team and partner on that team?
Good question, Amy. I appreciate you asking it. So a number of organizations do provide stipends to advisors who are participating in ongoing groups. And the reason they do that is to remove any financial barriers, because as I said, you want to have the populations on your advisory committees that represent who you serve. And some people have financial challenges or childcare challenges to being able to participate, but that voice may be very important. So it's important when you're recruiting and selecting people that you're asking them, is there anything that would prevent you from being able to participate? Would it be helpful if we provide you with a gas card or child care? And obviously, standard practice in a focus group is to provide people with often a gift card or a small token of appreciation. Some practices, other than removing financial barriers and providing financial remuneration for focus group participants, consider this a volunteer position, and there isn't an ongoing payment other than that payment which helps remove a barrier so that somebody can participate and wouldn't be able to otherwise.
I think that's really significant, Mary, is that oftentimes if you just remove those barriers to participation, and that can include having meetings with the quality improvement at times that the patient partners can participate. So it might, the best time for them to participate might not be at the lunch hour. It might be before the practice opens and before they have to go on to their job. Or in the evenings, and helping them secure some resources for childcare. I think those are great ideas, especially when you're getting started and you learn more about those patient partners and what kind of challenges that they're facing in terms of participating with the practice in this way. We'll have lots more information about all of this on upcoming webinars, please do reach out to us at the PCPCC if there are specific resources that you'd like to supply your practice transformation network practices, or if you'd like us to, we're going to be connecting you with patient and family leaders in your community, but if you'd like us to do that sooner than later, we can do some targeted work with all of you. So please do reach out to any of us through the Healthcare Communities portal or directly by email, and then we will be working with all of our partners throughout TCPI to help make sure that we get this engagement. Again, sooner than later. There's no time like the present. As soon as you're getting these activities kicked off in your practice, bring on your patient and family partners. So we are at the top of the hour. Again, I'm sorry we weren't able to get to many of the questions. We are going to have this webinar archived in full up on our website by the end of the day tomorrow, along with a copy of the slides. And then if you have specific ideas for content or information you'd like seen on an upcoming webinar, you can send us those recommendations as well. So thanks again to our speakers and our partners, and we look forward to working with all of you. Bye-bye.